Welcome to Window and Level. Here we break down complex radiology topics and adjust them for clarity. I am Zhenya Grick, your host, and this is our pilot episode on spontaneous intracranial hypotension. Today, we will be talking with Dr. Michael Noeske, who is starting his neuroradiology fellowship at Corewell Health Beaumont University Hospital this July. Let's dive in. Hello, Michael Noeske.
Hi, Jenya. How are you?
I'm doing good. Very nice to see you. Welcome to Window and Level. Thank you so much for being our first guest.
It's my pleasure. Thank you for having me.
Today, we're going to talk about intracranial hypotension. Is it true that it's one of your favorite topics?
That is true. And in neuroradiology, it's one of my favorite pathologies. So when you asked me to come on, I was excited to participate.
Awesome. Is there anything personal connection related to the topic or something strikes you about it that you really like?
So no personal connection in the sense of, I've never had intracranial hypotension and I haven't had a family member with it. But since learning about it, I've thought that the pathophysiology was very intuitive. So I liked that as it applies to the Monroe-Kelly doctrine. And I also just like the way that the imaging appearance on MR looks aesthetically. I think that it aesthetically looks nice. So kind of those two things together really make it one of my favorite pathologies.
Yeah, I definitely can relate. Some pathologies, they just vibe with you. And neuroradiology, it's one of my favorite topics too. So how do we start? What is the clinical context in intracranial hypotension? Can you explain to us in a couple words?
Definitely. It's a sort of a clinical condition that's characterized by the leakage of CSF from the central nervous system. And, for us as radiologists, there are radiographic findings that are present, and we can evaluate these on MR. And that's sort of something that we can do to evaluate for the presence of it. And as far as the clinical condition, patients generally present with an orthostatic headache, so a headache that's worse when standing up as opposed to lying down. And that's kind of the classic clinical presentation. And that's often something that the clinicians will be looking for when they're evaluating for a cause of headache.
That's true, right. This is the classic teaching. And do we have any atypical presentations of intracranial hypotension that can potentially fool us when we read the cases and come up as something non-conventional?
Yeah, although the orthostatic headache is the classic presentation, patients can present with a variety of neurological symptoms. They can have, neck pain, neck stiffness. They can have nausea, vomiting. They can have symptoms also related to cranial nerve palsy. So there is a variety of different presentations, but that orthostatic headache is the most common.
So it can definitely fool us by different symptoms, but it's going to be anyways accompanied by some kind of headache.
That's right.
So how do we catch these on imaging? What are the main findings?
Yeah, so I'll kind of just start with a brief review of the Monroe-Kelly hypothesis, which is kind of what I think is the basis of understanding the imaging findings. So that's the theory that within the brain we have, or within the cranium, we have this fixed volume that is composed of three components. We have brain tissue, we have CSF, and we have blood. And if one of these changes in volume, the others must compensate for that change and either increase or decrease. So in the case of intracranial hypotension, there's a decrease in CSF, and therefore brain tissue and brain blood needs to adjust to be able to compensate for this. So there's recently a mnemonic. I wasn't aware of this before, but I think that it kind of helps. Thank you for pointing it out to me, but it helps kind of these step by step. So the mnemonic is SEEPS, and these address how the system compensates for changes. So that first S is subdural collection. So you can have subdural effusions or subdural hematomas. So that would be blood filling the space. The second is engorgement. So engorgement of the venous system generally. So that's the venous plexuses, the dural venous sinuses filling with blood. So an expansion of the dura venous sinuses. E is then enhancement. So pachymeningeal enhancement. P is pituitary enlargement and enhancement. So that's brain tissue, which then expands. The pituitary becomes large in size and also hyperenhances. Then finally, S is sagging of the brain. So you can see particularly the brainstem, but the brain as well, more in the posterior fossa, sort of pulling down, and that also is the expansion of the brain tissue. So these are the classic findings. The most common of those findings is the pachymeningeal enhancement. In addition to these qualitative findings, there are also quantitative findings that can be used in assistance for diagnosis of intracranial hypotension. For instance, the AJNR recently released consensus findings related to the mammalopontine distance, and a distance less than 5.5 millimeters is highly suggestive of intracranial hypotension.
It's one of the most, I would say, striking things that we can miss, but at the same time, our eye catches it very easily. Like when you see that mammalopontine distance going down, it's probably very highly suggestive of intracranial hypotension. Does that sound right?
Definitely, yes. It's a very useful sign that can be used in making that diagnosis.
As far as we know, the chronic intracranial hypotension, be it spontaneous or iatrogenic, can be caused by a chronic CSF leak. So can you tell us a little bit about this entity, the CSF leaks, and maybe explain to us the types of them that are associated and causative of intracranial hypotension?
Yes. So as you mentioned, there are a variety of types of CSF leaks, and they're characterized based on both their location as well as what's occurring. So type 1, which is the most common type, generally occurs ventrally in the upper part of the thoracic spine. And it's important to note that these tears leading to intracranial hypotension have to arise below the hydrostatic indifference point. And that's the point in the spinal canal at which there's no difference in CSF pressure when the patient is moving between erect and recumbent positions. So that's why, tears in the cervical spine or tears in, the cranial vaults don't really cause this syndrome. So kind of going back to the first type, type 1, generally ventrally and involving the upper thoracic spine. The second type is a lateral tear, which often arises from meningeal diverticulum that can tear. And these can occur, like you said, trauma, that would be a secondary cause. So manual forces occurring within the spinal canal. And then there's type 3, which is a fistula, a CSF venous fistula, and that occurs between the subarachnoid space and the epidural veins. So it's CSF directly flowing into the venous system.
So ventral dural tear in the thoracic spine,
Mhm.
then lateral dural tear, the second type, and the
Yes,
third type is a direct CSF to venous fistula.
exactly.
Which one is the most common?
The first type is the most common.
The first type is the most common.
Hmm.
Yeah, this is amazing description of a classic teaching of spontaneous intracranial hypotension and dural leaks associated with that. And as you mentioned, we can see the signs of spontaneous intracranial hypotension on brain MRI. What are the optimal ways to diagnose the spinal CSF leaks?
Yeah, that's a good question. And it actually, I think, kind of, I'll describe like the potential treatments as well, because I think those two things, the further diagnostic imaging as well as treatment, sort of go hand in hand. So, you know, as you mentioned, the brain MR is sort of the standard of care as far as establishing the diagnosis from a radiographic perspective. What we do then generally is a non-targeted blood patch, and that's an attempt to sort of tamponade the region and cause a decrease in this leak and eventual cessation. So this can be attempted once, sometimes twice, and that's initially performed to see if the patient can have relief from their symptoms. If that doesn't work, that's when we move into the next segment of the workup, which includes different treatment as well as imaging strategies. So the first thing that's done is normally the myelography, and we do this as, unlike sort of the traditional myelogram, we do this as a dynamic test. So the patient is actually, it's generally performed under CT, and they're in the scanner and they're in a variety of positions to attempt to see the actual leakage. This is specifically or most commonly done for types 1 and 2. So the patient will be prone if it's concerned for a ventral tear, or if it's a lateral tear, they'll be in a decubitus position. If the leak is then detected, a targeted therapy, a targeted blood patch can be performed. So the blood patch can be injected at the level that they're concerned for the leak to be occurring. As far as type 3, the CSF venous fistula, these can be detected on the myelography, but sometimes it requires further imaging, something that has a better temporal resolution. So something like DSA, in which an interventionist can see the actual flow of the contrast from the spinal canal into the veins. This can also be attempted to be treated with a direct targeted blood patch, but I think an increasing technique that's being applied is embolization of the vein as a technique to control this fistula. Ultimately, if these techniques fail, surgery is a potential solution for these patients.
We actually just last week, a couple days ago, had to do a blood patch on a patient with iatrogenic spinal CSF leak after lumbar puncture. So it's something that we very commonly do for patients. I'm curious to hear your opinion on what's the biggest mistake that we residents do when we interpret images and either suspect or miss intracranial hypotension.
Yeah, so that's a good question. I think there's a couple potential pitfalls that residents need to be aware of, and the first is, or I guess misdiagnoses. The first relates to, I think, the pachymeningeal enhancement. I've seen this, and it's possible in my earlier years. I think there was a case where I actually raised the concern for meningitis. So meningitis, and another potential diagnosis would be metastasis. You can differentiate these. I think with metastasis, it's not going to be this symmetric, sort of more smooth pachymeningeal enhancement. It will be lumpy, bumpy. And then with meningitis, that tends to be more leptomeningeal. I guess there could be some type of clinical situation that you apply the patient's findings, although both patients could theoretically have headaches. But this, diffuse pachymeningeal enhancement is more likely to be related to intracranial hypotension as opposed to a meningitis. I think a second important pitfall that residents need to be aware of is not making the mistake of calling the sagging of the brainstem a Chiari malformation. So a lot of attention needs to be paid to a patient who, particularly an older patient who appears to suddenly develop Chiari malformation, not to make that diagnosis, because if it is in fact intracranial hypotension, a surgery to correct Chiari can cause worsening of the symptoms, and I think there actually have been some fatalities reported as well.
It actually reminds me before I go to my call tonight to make sure I pay attention to all of those. What would be your advice for me when I am on call at 2 a.m. and I am looking at previously undiagnosed SIH? I found it. What do you think I should pay attention to or raise concern for or just, give a heads up to clinician about?
Yeah, I mean, what you're looking for, the most common presentation is that pachymeningeal enhancement. So if you're seeing that there's a patient with a headache, that's, I think, the first thing that can really clue you in to the findings, and then that will alert you to look for some of the other findings. These patients typically do not present with all of the findings in that mnemonic SEEPS, but if you can link a couple together, it can put you on the right track.
So, since we are in the holiday season, I would like to close this podcast with something nice, cute, magical, and holiday related. Do you have any upcoming plans for this season? And how is Lucia doing?
Huh. Lucia, that's my cat. She will be 4 years old in a couple of months. She's doing really well, and no, nothing special. Just going back to spend some time with my family over the holidays, and looking forward to that. Spending time with family, and especially as a child, being away from school was always a nice benefit as well. So the time away from school and the time with family was always my favorite part.
Thank you so much for this review today, and it was a great pleasure to have you. Hopefully, we'll have more episodes with you later on, and you will keep revealing some interesting topics.
Well, thank you for having me on Window and Level, and I look forward to returning in the future.
Thank you, Michael.
Thanks, Jenya.
This is our episode on intracranial hypotension. Now I'd like to hear from you. What radiology topic would you like us to cover next? What case or finding challenged you recently? Leave a comment below, and your question might become our next episode. If you found this helpful, please subscribe. This is Window and Level. Thanks for listening.